This conference will now be recorded.
I thought we would start with JD's case because it's really kind of a cool, unusual lesion, and then we can go to Nav's case, if that's okay.
Yeah, that sounds great to me.
Okay. JD, do you have things that you need to present as far as ClinPath data, or are you just going to talk about the case first?
No, I can just talk about the case. I don't think I need to be the presenter.
Okay.
So the case that I'm presenting today is a dog named Izzy, who is a 11-year-old female spayed Pomeranian. And she has been proteinuric for the past 1.5 years, and she's been managed by her primary care veterinarian as well as an internist. And for the most part, with conservative management, ACE inhibitors, renal diet, blood pressure control, she's been pretty stable. And in the last few months, her proteinuria significantly worsened to the point where her most recent UPC prior to coming in to see me was 10.2. And clinically, she was still feeling pretty well. She had a decent energy level and a good appetite. Her overall kidney function seemed pretty reasonable. She's a Pomeranian. She had a creatinine of 1, which is a little bit higher than what I'd expect for a Pomeranian. And her BUN was a little bit high too, at about 50. So I think there's probably some decreased tubular function that she has, but overall she wasn't markedly azotemic. So she came to see me and we evaluated her, and we did an ultrasound which showed that there were some chronic changes to both kidneys. But we also saw from the ultrasound, because she is this quite small Pomeranian, she weighs 4 kilograms, that because of those chronic changes, we didn't really have a very great window for us to be able to perform ultrasound guided true cut biopsies, that the chances were going to be pretty high that we were going to have to go pretty deep into the medulla, or we were going to get just a very, very small superficial sample. So after talking to the owner, we, instead of trying the true cut biopsies, they were on board to go get a surgical biopsy. And so that's what we did. We took her to surgery probably a month or so later, just for scheduling purposes. And in surgery, the surgeons used one of the dermatology punch biopsies and obtained a couple biopsy samples for us. And we immediately processed them and then shipped them off for evaluation.
Okay.
When she saw us, I guess I'll just comment, her blood pressure, I think, historically had been elevated, and she was on amlodipine. For us, she was still normotensive, but her blood pressure was up to 170 prior to her coming in to see us. So she did have some hypertension, but it was controlled when she'd come to see us.
I think that's interesting to know, because I think some of her lesions are a little unusual compared to what we see in a lot of our cases. So we had a wedge biopsy, so we had a lot of glomeruli to look at. It was a great sample of subcapsular cortex. Hopefully you guys can see an H&E section. Yes?
Yeah, we see it, Rachel.
Okay. Yeah. Making sure. So the reason, if I cannot, I might use this to plug the biopsy service in the special skill sets that we have at this point in time. So we have structures that we can tell are glomeruli. I think this thing, to me, looks a little abnormal, and that's probably the afferent or the efferent arterial. But a lot of the glomeruli just look within normal range based on H&E evaluation. We kind of go over here. Go ahead.
Can you make this full screen?
Do you want me to go to make it higher, Meg?
Yeah, there you go.
So, but in general, I'm not, the good news for this dog is I'm not seeing a lot of interstitial fibrosis. I'm not seeing a lot of tubular damage. I just noticed that some glomeruli just don't look exactly right. And so this is a segment that's concerning at, 20x or 10x, which is where I'm at now. But then you have other glomeruli that look like they're within normal limits. So it is kind of a focal, it is a focal lesion. When we go to other stains, which are more helpful, and we go to that glomerulus that looked strange to me on the H&E, we can see actually there's solidification of this area, and we don't have very good capillary loops. Now this looks completely different than this more normal PAS glomerulus. So we have, again, that focality of distribution. And so it's about the trying to hone in on which are the glomeruli that are affected. We have some globally sclerotic glomeruli as well. One other glomerulus that also has kind of a similar loss of capillary loops, and also it just doesn't look as pink or as darkly staining as we would think an area of just regular old segmental sclerosis might look. So if it were regular old segmental sclerosis, it should be about this density of this dark pink or fuchsia color. So we have loss of capillary loops that is segmental. I've already said it's focal because it's only affecting some of the glomeruli, and there's a little bit of pallor to the staining, which is unusual. The other kind of key point is that even though there's a segmental problem in this glomerulus, the rest of the glomerulus actually looks pretty good. This is a good color of the matrix. These are pretty good peripheral capillary loops. It's not hypercellular. There's not a lot of circulating inflammatory cells. The PAS also is kind of good because we weren't able to see on histology, but there actually are some atrophic tubules. These guys used to be tubules over here, and now these tiny little outlines. So the PAS can kind of highlight that tubular atrophy, which we could not see on the H&E. And now I'm looking for my silver stain, and I can't find it. 1 second. Silver. Oh, here it is. Never mind. Right. So if this were a typical case of FSGS, focal segmental glomerulosclerosis, I'm going to expect that only some of the glomeruli are affected, only portions of the tuft are affected, and then that sclerotic segment should be dense black on the silver stain. It should look like consolidated extra matrix. And so we go to our 2 glomeruli that are most severely affected, and it's not black enough. So this whole area should be densely black if this were just segmental sclerosis. And so the fact that I have some gray pallor here and some irregularity to that region, a little bit of lucency, it's actually technically lucence and dissolution the mesangium, made me text JD and say, hey, your dog is weird. I think it's a mesangiolitis type lesion. Here's another one. So this is a glomerulus I showed you before with the PAS. And so if this had just been FSGS as a disease process, this whole area should be consolidated in dark black. And instead, we have actual dissolution of the matrix. So I think at the prelim for the biopsy was focal segmental mesangiolitis. And I kind of waxed poetic on what could be the cause of that. But it's pretty unusual in our cohort of about 2,000 cases that we've looked at. So, and then you could go to other glomeruli that look pretty healthy. They've got great peripheral capillary loops. There's no evidence of remodeling of that glomerular basement membrane. They might have a little bit of mesangial expansion and maybe a little bit of mesangial hypercellularity. However, those are very non-specific lesions. I mention them, and I always keep them in the report, but it's not very indicative of a certain disease process. And then one last thing I want to show you is the trichrome. So we mentioned about the hypertension and whether or not this dog had any degree of hypertension. It's kind of refractile. So if we are looking specifically at the vascular poles of a lot of glomeruli, and again, this is a focal lesion, it's only affecting some of the glomeruli. We can see actually expansion of the arteriolar wall. And I think these are mostly foam cells in here, or foamy macrophages, or they could just be vacuoles within the smooth muscle cells themselves. It's hard to say, but I'm concerned about that vascular change. And then other arterioles, we again have almost occlusion of the lumen, although it's possible we might be dissection of cut. But really, we're not having very good lumen in these afferent or efferent arterioles. And I don't know how to tell the difference between afferent and efferent. So let's go to our last. Oh, he doesn't have a good vascular pull. So that was kind of my working diagnosis with JD. Oh, here's another good vascular pull that seems like it's not within normal limits. Very thickened wall, and again, very small, narrowed lumen, and there's some thickening of the afferent or efferent arteriolar wall. Any questions so far about the histology? Is anybody there?
Yeah, we're here.
Hey, Rachel, do you happen to see the mesangiolisis with other conditions? Is that something that you've seen with as a feature of some immune complex GNs or with other different etiologies?
That's a really good question. And so mesangiolisis, the term just literally means dissolution or lysis of the mesangium. And it is uncommon in animals. Sometimes we will see severe mesangiolisis with things that are most like envenomation events or snake bites or bee stings, where there's many, enzymes that are basically probably circulating out in the blood and able to digest the mesangium. So that would be pretty much every single glomerulus is affected. It looks a little bit different because the mesangium dissolves in such a way that everything that used to be a tortuous capillary now gets blown out into an enormous single capillary loop, and it's just chock full of red cells. So that could be one extreme of mesangiolisis to, the whole mesangium has just been dissolved, and now something that was a very long tubular structure is just a blown out single dilated or aneurysmal dilation of the capillary loop. So in dogs and cats, that would be one thing on my list. But mesangiolisis actually is even a step in diabetic nephropathy of humans, where they have a mesangiolisis event originally, and then they start to deposit a whole bunch more matrix in that dissolved mesangial zone. And that's what forms that Kimmel-Stowe-Wilson nodule that we talk about in humans with diabetic nephropathy. So there are a lot of things that we think can cause mesangiolisis. It's just that we don't get to see that often in dogs or cats. I'm trying to think of other situations where I've seen it. And I don't know, George, do any of the other things bump into your mind? I think pancreatitis can be associated with mesangiolisis, although we've seen lots of kidneys from pancreatitis animals, and it's not a common feature. Anything else, George, that you think of? Are you muted, George?
I can't recall any specific associations that. Let's reemphasize that this is a pretty uncommon observation, and even in this dog, it's segmental, and in only 4% of the examined glomeruli in the sections examined. Now, because it's segmental, it could be affecting some glomeruli that are affected in a plane other than the plane it was sectioned in, and so that it's a sampling error or not, but it's still this dog's not that they're perfectly normal, but mesangiolisis is not apparent in many of the glomeruli examined, and so it may be just a goofy accident,
Rachel, I have a question. So in these zones of mesangiolisis, what's there? I'm presuming that the mesangial cells are disrupted or dead, and the matrix has been digested. And so what's left in that space? Just some protein goo?
That's what we usually think. And I mean, obviously it's about the stage as well, because eventually it would try to probably scar down. So, and unfortunately, the glomerulus that we had for EM, which is a very good glomerulus and it helped us make the diagnosis, it didn't have that segmental mesangiolisis, so I can't definitively say what would have been present in this dog. But you know, usually it's just kind of when you look at it on EM, there's just rarefaction or poor. It's not as osmophilic as normal mesangium is, and you really don't have a lot of the kind of fibrillar nature that you would think of regular mesangium. It has a different quality on EM. Sorry, I'm taking a bite of bread. 1 second. But that's what we had on light microscopy. Is it right if I go to the other 2 studies, or does somebody else have more questions about microscopy? Okay.
I think you can.
So I think I had said originally focal segmental glomerular mesangiolisis and glomerulosclerosis. And so these were the pictures I took for the report, and I focused on those weird ones. And then I said that other ones had vascular disease, or glomeruli had vascular disease, but not necessarily mesangiolisis. And so one of our glomeruli for the EM was, well, actually, hold on. How do I want to do this? Yeah. One of them was completely sclerotic. And then the others were a bit of a surprise, or at least it helped us make the diagnosis. So here we have a capillary loop, and, you know, this is an area of, it's really always hard to say whether or not this is a branch point of a capillary loop, and so maybe mesangium would be down here. Either way, we have these electron densities that are kind of along this zone near the lumen. We have mesangial cell interpositioning. This stuff that I'm outlining here is actually mesangial cell cytoplasm, so it's kind of intermixed with the electron dense deposits. And so if I only see 1 or 2 of those deposits, I can't make an entire diagnosis of immune complex disease with just 1 or 2. I have to look and make sure it's repeatable. And so along a lot of capillary loops, I have these little bit of electron densities. I have mesangial cell interpositioning, which is this thing right here that I'm outlining. Hopefully you guys can see. And there's a little bit of lucency kind of in here as well, as these deposits are kind of being put down here, and maybe the mesangial cell is growing in there as well. And it kind of goes all along, but you can often see that associated with these deposits, we often have mesangial cell extension around that area. This area was at the vascular pole. This is the 3rd glomerulus, I think. And it was at the vascular pole where near a vessel that was damaged. So what we saw in that white space on the trichrome stain that I pointed out to you about that efferent arterial is now slightly osmophilic, so kind of consistent with lipid in that efferent arterial. So this is helpful at least for observing the vascular disease. And this is that capillary wall that's going up towards, arteriolar wall that's going up towards that glomerulus. And we have degeneration and vacuolation of the smooth muscle cells in the tunica media. So there's definitely vascular disease in this dog. And we have evidence of electron deposits. They're not huge. They are almost always either in or within the mesangium. And often, even if they get out into the peripheral capillary loop, there's usually mesangial cell interpositioning at the same time. So, okay, now I have an immune complex process. Realistically, I have more evidence for that. And then when we went to the immunofluorescence microscopy, what's obvious from this picture is that the IgA is the strongest staining immunoglobulin we have in this case. So IgA is much stronger than IgG. This is quite a surprise to me because we don't normally see IgA being a dominant immunoglobulin. And so I had the lab repeat it twice just to make sure that I wasn't, the slides didn't get switched or get mislabeled or whatever. And it was repeatable that the IgA was very, very strong compared to the IgG being kind of weak to moderate, probably more weak. Hold on. Okay, so there is a little bit of activation in the complement system in this glomerulus. We can see some granular staining with the C3, but for many of our traditional ICGN cases that are like the MPGN cases, membranoproliferative cases, the C3 is usually a lot stronger than what we're seeing here. I mean, it's present here. We know we've activated a complement system somehow, but it's not nearly as strong as we see with a lot of our immune complex cases. The light chain, this intensity is about the same as the IgA, so most of these light chains are probably bound to IgA molecules. So it's an unusual case just because the mesangiolisis is an uncommon lesion in dogs or cats, and that the IgA is the dominant immunoglobulin, which might be why, if that's as unusual as the mesangiolisis, then maybe what we're really truly seeing is a true IgA nephritis or glomerulopathy, I guess we should say, and that's part of the mechanism of this patient's mesangiolisis.
Rachel, when you were showing the Jones stains, I almost had the impression that there actually were holes there. Was that just my naivete, or could you actually identify that there might be some holes in the black areas that were probably more mesangial?
So we really try to limit our interpretation for the mesangial part of the Jones stain. I know that when we look at capillary loops, we would look for holes or spikes in support of a membranous pattern of immune complex deposition. But when you get to the mesangium, just thinking about what's there, so there should be cytoplasmic projections there. You often get a little bit of lipid in the mesangium of most dogs. So a lot of those things would be non-staining as well. And so I don't make a call because I could see misinterpreting a lipid droplet as a whole because there's an immune complex. You know what I mean? So I probably try to ignore how the mesangium stains, other than to say it's less staining than I expect. But I don't think I would ever call a discrete hole or spike or some type of remodeling in there, just because there's so many other things that should be mixed into that matrix.
Larry, it's mesangial matrix that stains dark in the mesangium, and even just the mesangial cells will make a hole. So
okay,
that is the cell body. Yeah.
Any other comments or questions about this? We don't have a lot of IgA cases. When I looked at this last time, I was trying to put some kind of documentation together about what we see. I think IgA has been listed about 10 times out of 2,000 cases as being like, hey, this is pretty much IgA dominant. I haven't come back to that list to see how many of them could have had mesangiolisis at the same time. But as George pointed out, this was a small part of the number of glomeruli in the whole sample. So if we only get 10 glomeruli and it's a mesangiolisis case, it's very possible, if we only get 10 glomeruli and it's an IgA case, then it could be possible that we might miss this. But IgA glomerulonephritis in humans, which is almost always due to a different isoform of IgA. Dogs and cats just don't make that isoform. They don't make IgA2, they only make IgA1. And so that's why we don't see it in dogs or cats. But in humans, it's usually mesangial deposition. It sometimes goes out into the capillary loop. There's mesangial hypercellularity. And there can be areas and times where if it gets an inflammation, or maybe the patient has like a cold or something like that and activates his immune system, then you can have segmental fibrinoid necrosis, you can have crescent formation, you can have mesangiolisis. So it can be like a somewhat similar lesion to what we're seeing in this particular case. But that's all humans, and it's a different form of IgA, and dogs don't make that kind of IgA.
Any speculation on why the IgA would dominate in this one? You know, anything about the production of IgA or disease conditions that might invoke an IgA antibody instead of other ones that might precipitate in this lesion?
I don't know. Do you have any idea of mucosal oriented inflammation, JD?
I think that was really pronounced in the patient. The patient could potentially have Cushing's disease, but that's really it. And then if you look at the list of diseases in people that are reported with IgA nephropathy, which again, maybe that list doesn't pertain because they're different immunoglobulins, but it is typically seen secondary to or coexisting with many different types of cancers. infections like HIV and Hep B, as well as some autoimmune disorders like rheumatoid arthritis and uveitis, even myasthenia. You can see it concurrently. So, and in people that they certainly don't have a great understanding of exactly how to manage it, because if there's an underlying disease that can be treated, if it's a patient with good function and moderate to low proteinuria, they're just going to continue to watch them and not do anything. So this patient doesn't have any of those obvious conditions that are reported in people. I don't think Cushing's was on the list, but that's the only thing that concurrent disorder that this patient might have. So therapeutically, based upon these results, I went to the human guidelines, and in dogs with moderate proteinuria with some decrease in GFR, they recommend optimizing supportive care for about 3 to 6 months. She's already had that. She came to me after a year and a half being on supportive care. And if there is decreased GFR, which I do believe there is in her, with her BUN and creatinine being what they are, a immunosuppressive trial is offered. And they typically use corticosteroids. I did not choose to use corticosteroids in this patient because of the concern that maybe she could be cushingoid. So I decided to use mycophenolate because we have personally the most experience with that drug, and I figured why not. There's a little bit of data about mycophenolate and IgA nephropathy in people, but it's not nearly as commonly used as corticosteroids. But that's what we did. We used mycophenolate, and after about 5 weeks of the mycophenolate therapy, she had recheck lab work performed, and her UPC went from 10 and is now 1.8.
Wow!
Yeah, I just got that back this week.
Well,
and I
that's
think
fun.
Yeah, I'm pretty excited. Obviously, I told the owners I'm not really sure exactly how everything's going to go because I've never managed another dog with IgA nephropathy or presumptive IgA nephropathy, but certainly waiting and continuing the supportive care wasn't going to likely help. And she seems like she's doing better, and overall, very pleased. We'll keep an eye on her and pretty close tabs, and collect all this data that we'll share in the database so that we can be prepared the next time someone gets one of these cases to have some other clinical data to provide a vignette of what could happen to some of these patients.
So you're putting all this clinical data in Vision?
I either put it in, or more often than not, I usually just forward all my labs to Rachel, and her team usually throws it in.
Or we have it in our big pile of other things to enter. So we have so much data that we need like a data entry set person. So every so often we can get a bulk of some of that entered. Jessica just texted me, Dr. Hokamp just texted me and said if the next time she comes in and you want to have more, if you want to take urine for the SCS page, she'd run it for you, obviously, for follow-up.
Yeah, that would be awesome.
And I think I'm gonna probably rewrite this diagnosis, and I'm gonna say IF and EM evidence of immune complex deposition. I know it's gonna be a really verbal, like a wordy diagnosis, but I want to make sure that it is clear that there's EM evidence of immune complex deposition too, and that it's mostly IgA. So I'm gonna probably just wordsmith this a bit. If you want me to send you the updated report, I can, but I feel like I need to clarify that there's EM evidence of immune complexes in here as well.
Sure. Yeah, I can always grab it, but if you email it to me.
Things. One, to answer Larry's point, when the follow-up information gets to me, what I actually do is prepare an addendum to the clinical synopsis that provides the information and who provided it and when it was transmitted to us about follow-up information like this. And so I just put it in an addendum that appears in the report. Number two, Rachel is talking about refining the diagnosis statement based on things. And three, there's actually a typo in the top of the report. The case accession number for the pathology is got a misprint in it. So
Oh, okay.
if you do all those things, I'll make a brand new report and send it to you, and
Okay.
it'll include everything. Okay.
That sounds good.
Since you didn't have a lesion that had the mesangiolisis in the EM, could this be two diseases? I mean, is that tenable? And what would be the speculation that these immune deposits would predispose to the mesangiolisis?
It's a good question. I think that I think this is multifactorial, and that's probably why we don't see it that often. But even with the IF, I think you can see the strongest staining is in the mesangial zone. And there are a little bit of capillary loop granularity staining, but like here's a capillary loop that's not staining. There's got to be capillary loops in here that aren't staining. And so it's mostly mesangial prominent deposits. And then as we saw in the EM, whenever we had an electron dense deposit in the peripheral capillary loop, we also had mesangial cell interpositioning at the same time. So we've activated the mesangial cells at some point. I also wonder if some of that vascular disease with either the foam cells or the lipid within the arterioles is making perfusion to be abnormal, because that, a very weird range of hypertension or perfusion of the glomerular tuft could technically blow out a region of the glomerular capillary loops and have mesangium because of almost technically like an edema process where fluid is getting pushed into that segment. And so maybe both of those things are acting together. And it's a Pomeranian. So was she dyslipidemic? Do you know at all, JD?
I don't so, but I'll have to double check. I don't think that she was.
Okay. Because that'd be one other thing to kind of follow with her, because she did have at least 3 or 4 glomeruli, 3 on light microscopy and at least 1 in the EM specimen that had evidence of lipid accumulation and foam cell accumulation in those arteriolar profiles. So I kind of wonder if she's going to eventually have almost like a separate injury to her glomerular tuft because of all that lipid that might be including the lumens to those particular glomeruli. So, but I'm trying a lot better to characterize those vascular lesions in dogs and cats, especially when it's in the afferent arteriole, to try to not quantify, but take note of when we see lipid in that region. So.
Back in March
so
was the last time that she had cholesterol and triglycerides measured, and they were both normal at that point. Okay. And she had a UPC of 8.3 in March. So, yeah, so fairly proteinuric, and she had normal cholesterol and triglycerides.
Okay.
Sort of argues against the Cushing's, though, too.
It's true.
I would agree. That's been a more recent change, and the referring vet's more excited about that than I am at the moment.
It's weak evidence. It's just leaning the wrong way.
Hey, JD, if you weren't, if there wasn't a concern of Cushing's, do you think you would have treated this dog with corticosteroids instead, like a person, or would you still have opted for the mycophenolate?
Great question, Nav. I don't know. I think that maybe I'm a wimp, and maybe I'm not using corticosteroids for this. I mean, as much as I should. We use them so much for everything else in the world, but I somehow have some resistance to add on the side effects of the hypertension, hypercoagulability, and all those things that we worry about anyways with these patients. And I guess I probably still would have tried mycophenolate, and if we didn't see a response, then at that point I probably would have tried steroids. That's personally what I would have done. I don't know if anybody would have done anything differently.
Yeah, that sounds about right.
So I do think so. Obviously, I have a checklist of things that need to get collected and studied and published. And one of them is lesions of juvenile nephropathy. But the other one is kind of what do we do with this mesangial proliferative, mesangial immune complex dominant? Some of these do have IgA evidence. Some of them are regular IgG, but I need to kind of figure out how best to report the variation in the lesions, and then also for you guys to figure out how to suggest treatment. Because when I get this case and say it's not one of you guys, it's a practitioner who sent me 10 biopsies, so I trust them. They've sent me lots of biopsies, but they're not in our circle of friends, if you will. I try to tell them, like, I think optimizing renal protective therapy is the best first step, and that if the patient progresses, or if azotemia develops, or azotemia or the proteinuria doesn't go away, that immunosuppression is a valid option. But I just, I feel very worried about saying that as a pathologist, trying to give them the idea to immunosuppress, when sometimes maybe it's just those deposits are just going to sit there in the mesangium and not do much. So I think we kind of need to attack this disease as the new next entity, so that we can get that data out there. Do we want to move on to the second case? Actually, it's kind of two cases, but one of them is almost a recheck, and then a brand new case. Is that okay, or are there other questions about this weird case? I don't see anybody typing anything in our chat thing, so I think it's fine. So I guess I'll move on. Yeah? Okay,
Good.
let's do it. Now, do you want to start your clinical history?
Sure. I don't have anything that needs to be shared, like screen-wise, so I can just kind of talk about them. So one of them is a dog that I presented a while ago, Bailey Conrad, and I guess the reason for, I just thought it would be interesting to share these two cases because they're two immune complex GN cases that have just clinically responded very differently, and I think that from the standpoint of us kind of as a whole, just kind of using steroids and mycophenolate as our primary immunosuppressive agent, like maybe we should be doing things differently, and maybe looking at the biopsies for how animals respond differently would be helpful. So these are two cases that were biopsied around the same time. The first one is Bailey Conrad, who's up on the screen right now, and she was evaluated for an acute onset of proteinuria. I won't really talk about her, presentation previously, but she was an azotemic, proteinuric, hypoalbuminemic, hypertensive PLN that we ultimately biopsied and started immunosuppressive therapy after a diagnosis of immune complex GN. And she responded great to therapy, and on subsequent rechecks, she eventually became completely non-azotemic, non-proteinuric. Her last UPC, I think, was in the 0.5 range, and her creatinine was around 1.0. And in the hospital, at her initial presentation, it had creeped up to around 6 or 8. And her albumin had been 1.8, and her albumin is now well within the normal range. So she's been doing phenomenal. I don't have any of her data just because all of her stuff is at my previous practice, so I don't have access to her medical records right now. But we last checked her at the end of August, and at that point she had been on mycophenolate for about 16 weeks, and we had started tapering her off of the mycophenolate, and she's still on the standard therapy, and as far as I know, she's still doing very well since that tapering has been made. So she's doing phenomenal. The other case I can kind of present quickly right now, and then maybe we can talk about the biopsies together. But the other one is a patient, Roscoe, 6-year-old castrated male hound cross that was presented for an acute onset of lameness and some focal effusion or edema in the left hind limb, but had a shifting leg lameness, and was anorexic or hyporexic for about a week. On presentation at the primary care vet, was found to be azotemic with a creatinine of 5 initially, and was hypoalbuminemic as well at 1.4. Was also found to be Lyme positive. This is a dog that goes hiking very commonly and kind of goes swimming every day in a local, like a river kind of nearby. And so was referred over to us for further evaluation. We did a pretty thorough workup and did ultrasound, which just showed some lymphadenopathy, which was mild. The creatinine that we rechecked was around the same, around 4.3. The albumin was 2.1 and was hyperglobulemic. Was glucose uric and proteinuric with a UPC of 9.8, and also had mild hematuria and pyuria. Urine culture was negative. We did lepto-PCR on blood and urine, which was negative, and lepto-MAT titers were in the like 1 to 50 to 1 to 200 range. Without any, we didn't end up doing convalescence on the dog just because the dog was progressing pretty quickly, and we decided to proceed with biopsy once we got all of our initial information back. We did treat with doxycycline. I also want to mention the dog was Lyme positive on a SNAP test, and then it was confirmed again in hospital. The owner kind of wanted to think about whether to proceed with biopsy for a little bit, so we treated initially with doxycycline and kind of some other standard therapy. I think we held on the ACE inhibitor at that time because we weren't sure if there was a component of an AKI. And then on the day of biopsy, recheck values were creatinine was 3.0, albumin was 2, was hyperphosphatemic, had never been anemic, and the blood pressure, which initially was 200, had responded and was around 165. And that's when we performed renal biopsies. Coag testing was normal, platelet count was normal, the CBC was pretty unremarkable.
Now, did you have Lyme titers?
We didn't pull like a C6 quant, and I don't think the primary care vet had done that either. And the dog hadn't really been to a veterinarian in a while, so we don't have previous records on it. So this was the first time that the owner was aware it was Lyme positive, but not really sure historically. Do you want to talk about the biopsies, or do you want me to kind of tell a little bit about how the dog's been doing?
Hey, so I have I'm on another call. Can you, 1 second, hold on, sorry.
Yeah, that's okay.
While she's on that call, Nav, how is that dog doing?
This one, Roscoe?
Yeah. Mm-hmm.
Not well. I rechecked it recently, about a week ago, and the dog had developed some edema, which other than that kind of focal hind limb stuff that resolved actually by the time of biopsy, the dog had never really been edematous, and the dog had pretty substantial interstitial edema kind of diffusely. The creatinine has been progressive and the azotemia has been progressive. I think the most recent values, the BUN was like 150, the creatinine was around 4 or 5. So depending on what time point we're using, it's about the same or increased. The albumin has improved with therapy, and we started immunosuppressive therapy. The UPC has increased from the 9.4 to 18.4. The dog has not been on an ACE inhibitor because the dog has not been eating really much of anything. We did not place an E-tube at the time of biopsy because the dog had been eating actually pretty well and was eating pretty much, entire cans of renal diets for the week leading up to biopsy. So the owner elected not to place a feeding tube. So the dog has really only been eating like some cooked meats and occasionally some kind of generic dog food. But overall, the dog has not been really doing great. The owner also initially I had started a immunosuppressive protocol with steroids for 2 weeks, and the intention was to have it be like a 2-week tapering course as we started the mycophenolate. The owner didn't really get the memo or kind of misread the instructions, so she had been continuing the 2 mg per kg per day of prednisone, and the dog's been on that for about a month, which is not great for the numerous reasons we just talked about. So at the last recheck, I had her taper that pretty quickly, so the dog's going to be getting tapered off of its steroid. We were also able to stop the doxycycline because he's been on it for a month, And kind of as we've kind of come off a lot of these medications, she emailed me the other day and said that he's actually been doing pretty well over the past few days and is starting to eat again and things like that. So I would say he's probably static, but he hasn't really had a response as far as his disease goes.
Yeah. Thank you.
Yeah.
Sorry, I'm back. I apologize. I realized that I have the same picture for picture number 3 and number 7. Sorry. I'll fix that. So I think if we want, and I plan on just going by the images just for time's sake. I think if we were to compare the histopathology of both of these cases, they both have hypercellularity. So this is Bailey, the dog that's doing fairly well, or doing really well actually. And so they have a lot of hypercellularity of the glomeruli in both Bailey and then in Roscoe. One of the main things that I see as a difference is that there's a little bit more chronicity to the changes in Roscoe. So a little more loss or effacement of capillary loop, periglomerular fibrosis, and a lot of more interstitial fibrosis. So it looks like this particular glomerular disease has been going on for a little bit longer. On this trichrome stain, we can actually already start to see these red nodules, which are probably going to end up being deposits. And then on the silver stain, we can see a little bit of evidence of remodeling of capillary walls. If I go to a little bit higher mag, the double contours out here, you can see a little bit of a black line, a clear line, and another black line. Same thing in these certain segments where there's just a little bit more evidence of remodeling of these capillary walls. Here's a great example of this capillary loop, a dark line, which is part of GBM material, a little bit of lucency, and then another dark line. So it looks like Roscoe's has been around a little bit longer, and maybe that's why we have more chronicity. If we do that same comparison on Bailey, we just see one single dark line, and it very well could be like a light stain day. I think we had to use the glutaraldehyde sample for this, but even so, I'm not seeing a lot of double contours on Bailey's specimen. Shoot, I closed Roscoe. 1 second. Hold on. Okay. Oh no, I know what I did. Okay, so then, but at least I was able to say from looking at histology, it's probably going to be, it's definitely proliferative. I have evidence of remodeling. I'm pretty sure there's going to be new complexes here based on the trichrome. And then this whole area is a segmental scarred part of the glomerulus that's adhered to Bowman's capsule. So we already have scarring of these glomerular tufts in Roscoe, the one that's kind of progressing more quickly. On EM, his glomeruli were the classic mantra of it's very hard to see where you're at. So this is a glomerular tuft, but it's really hard to say, I know this is a capillary loop and I know that that's mesangium. Here's a single red blood cell that is trying to, be a weird shape, just to be able to fit through this capillary lumen. And then all of this is capillary wall. So there's a lot of chronicity in this glomerulus that's on the EM specimen. We have a lot of really prominent deposits, and we even have some mesangial interpositioning for the pathologists that are calling in, which I don't think there are that many, but we can clearly see a cell membrane around here, so that's mesangial interpositioning, whereas there's no membrane bound around this stuff, so these are deposits. Again, the deposits are mostly in the subendothelial zone, and also kind of at the mesangium, kind of going out as the neck of the mesangium. And then, these are probably endothelial cells because they look like they're continuous with endothelium over here. And that makes this the little bit of lumen that's left. And so really hard for that to have a normal circulation pattern in that glomerular capillary loop. So deposits are pretty extensive, and there's a lot of remodeling of the capillary walls. I'm trying to think if there was anything else that was really prominent on this case. This whole area, we don't have hardly, I don't even think we have an open capillary loop on this particular glomerular capillary wall. So the IF on Roscoe was a little bit weird because there's been a lot of background autofluorescence on some of these cases. but we at least can say that there's discrete granular staining along the mesangial zones and capillary loop present for IgG and IgM. The C3 looks gorgeous because all we see is staining of the glomerulus. So prominent granularity in the C3 staining and lambda light chain. This part here that's really smudgy and glowy is probably an area sclerosis or maybe hyaline or something like that. But I try to take the same glomerulus for each picture, so that's why it looks like that. So immune complex GN with the proliferation, it's a membranoproliferative pattern, and it just seems like he has a lot more chronicity than Bailey ever had. Any questions? What did you see on the urine, Hocamp?
Yeah, so I didn't have an early sample from Bailey, but I did for Roscoe, and not surprisingly, of course, there were severe glomerular proteinuria. But what's interesting on this one is that it had what I call a very high molecular weight band, where it's basically just sitting in the top of the well. And the vast majority of the time when I see that, it's always an immune complex mediated proliferation. So I think I called or texted Nav that day and told him that that's what I thought it was, but we needed a biopsy. So at least we were right on that. But just those really, really high prominent molecular weight proteins.
I mean, I think that this is kind of like a good illustration of the concept of if you think the owner is going to eventually go for a biopsy or is going to be okay with immunosuppressing a dog, like talking them into it early can really impact the ability to rescue that dog, because, I mean, there's just a lot of background tubular interstitial disease already. We've got pretty bad vascular disease, the vascular pole of this glomerulus. So there's just so much scar now that you're going to have to fight against. And so even if you were able to get rid of all the immune complexes or no more immune complexes were being made, you still have segmental sclerosis you've got. So there's still going to be some degree of proteinuria. You've damaged a lot of, the dog has damaged a lot of podocytes. So it's really hard to come back from that. Other thoughts?
Yeah, so Roscoe's one that I'm kind of debating at this point. Like, if he really hasn't responded well, do I, is it because he hasn't really seen the benefit of an ACE inhibitor just because he hasn't really been tolerating it? Or do I need to try a different immunosuppressive protocol if mycophenolate might not be working? Or is it all just mostly related to the chronic changes that you're seeing on biopsy that are resulting in his persistent proteinuria and azotemia? I think the fact that he's been on such high dose prednisone for a month doesn't help as far as confounding some of the proteinuria results, but I don't think I can explain all of that change on just being on steroids. I wonder if he's one that, do you think rebiopsying him could potentially provide benefit if there's still significant evidence of active immune complex disease? Maybe there would be more indication to switch his immunosuppressive protocol versus not really going down that route.
Let me speak for a moment. The first thing, and Rachel has emphasized the word chronicity, and that sort of is the general idea, because these changes take time. But the important point isn't the chronicity; it's the magnitude of structural change in the second dog that isn't present in the first dog. The first dog's change is almost entirely hypercellularity, and the non, if you will, the extracellular matrix component of the change in the first dog is relatively minimal, whether you talk about it inside the glomerular compartment or extended out into the tubulointerstitium with the interstitial fibrosis, whatnot. Regardless of how long it takes, the extent or amount of structural change in non-cellular components of the second dog's glomeruli is it's not subtle. I think it's huge. The proteinuria may be exacerbated by the the steroids, if you take a non-immune disease like HN and just give dogs with stable proteinuria a milligram per pound per day, and of prednisone, you end up tripling the UPC. And if you take them off of it in 2 weeks, the UPC goes back to where it started. And if you have actual dogs with Cushing's disease with a proteinuria, I've talked to people that told me about their cases and UPC of 20 and take it off, get the nothing changes except get their Cushing's under control. UPC dropped to 2, and so when there's some cause for proteinuria, that the prednisone effect on the kidney seems to worsen the proteinuria unless it actually directly, substantially alters the fundamental underlying disease. And I'm not sure, except for maybe lupus or something like, highly steroid responsive immune disease, that steroids help much, except maybe in the early phases of really acute inflammatory process to shut that off a little bit. But the key thing here, as far as I'm concerned, is that you might be at this point happy that the dog's still alive, the second dog, because of all the structural change. It is going to take a lot of time, in addition to immunosuppressive therapy, to get as good as it can get, and it's probably limited the amount of good as it can get that it can achieve because of the structural change that is semi-permanent.
Right.
In response to Nov's question about, should I continue the immunosuppression or not? I think, George has sort of alluded to the fact that the steroid's probably not a good idea in this case. The other question that I've always pondered when we were in the project was, can the histopathology give us direction on whether this is a disease that's still immune active, or is the immune component of the disease now quiescent and probably no further requirement or benefit from the immunosuppressive therapy? So I throw it back at you, Rachel and George. Are the deposits in this dog, are they so enveloped and deep into the membrane at this point that we don't identify that there's new active immune deposition?
Well, one thing we'd say is that the C3 is lights up on the immunostaining. So we would, on the basis of the immune deposits activating C3, regardless of whether their level within the capillary wall and thing, would suggest that it's an active, ongoing contribution to the downstream effects of the immune complex deposition on and the cellularity. So at the time of this biopsy, the answer is, I think, yes. Now, I don't know that I'd rebiopsy in just a month with all the things that have been, or 2 months or however long. But, if you optimize everything else and go out, 4 to 6 months and are wondering whether or not continued immunosuppressive therapy with mycophenolate, or, we might revisit the idea of activity of the immune process, partly with EM, but also with the immunostaining guidelines and a light microscopy with respect to the cellularity component of it and what's happened with regard to, these injured glomeruli are either going to repair a bit or, fall completely out of the functional pool, in which they'll become more globally sclerotic and whatnot. And so you get a sense of direction maybe from that, but not right now.
Yeah. That's a good point about the C3. But I've had cases where, there'd be very obvious immune deposits. The immune deposits were old. We treat with immunosuppressant for months and nothing changed. So I think that the pathology, as you're just suggesting, in this case, particularly the immunofluorescence, does provide some guidance as to what to do.
I agree. I know that we have suggested or told you guys on this conference when you've been able to call in that HoCamp is very interested in following these patients that maybe you guys have already done a biopsy on and it's just coming back in for recheck. If you could grab urine for us, I mean, you don't need to do the whole spin downs anymore because Dr. Hokamp has modified. So just grabbing urine for us and sending it off, then that way we can continue to follow it on a gel and see if the protein profiles go away or change over time. I think that's kind of, I mean, I think even that piece of knowledge of following that type of biomarker over time would be of interest. So
Yeah.
it's 5 after 1, so I wanted, oh, go ahead.
No, I was just saying thank you for plugging that.
One last point. So Rachel, what I'll do is I'm going to create a Dropbox that we can put these recordings in, give you and JD access to the box, and then we can create a link that we can send out to the list. So anybody that wants to review these sessions can do it.
That sounds great. Well, it's 5 after 1, so I think it's probably time to wrap up. I need to go back and check on our horse that's being autopsied. So, and I think I'm meeting with, we're having a WSAVA thing on Wednesday. Is that, or sorry, Tuesday? Is that correct, Larry?
Next Tuesday, right?
Yeah, I think so. Okay, that sounds great. And let us know. We'll have another set of these rounds. I know it seems weird because sometimes it's the third week of the month, third Thursday of the month, and sometimes it's the fourth Thursday of the month. Honestly, it has to do with when I'm on autopsy and when I'm not. So if I'm really, really busy, I just can't work it into my schedule. So I know it's annoying for sometimes it seems to switch around, but at least I try to give you guys a week heads up to ask for cases if you're going to be able to attend. So thank you so much.
One last comment before we quit. So the American Society of Nephrology meeting this year is the last week in October here in San Diego. I encourage anybody who has an interest in nephrology or nephropathology to attend that meeting. We also, and I'll be sending out an announcement soon, typically when the meeting's in San Diego, we host a reception at our facility here, and you'd all be welcome to that, but I'll need to know who's going to attend the meeting. First, encourage you to attend that meeting, and secondly, if you're going to attend the ASN meeting, let me know so that we can invite you to our reception.
Sounds good. Thank you guys for calling in. Bye.
Thank you too. Very nice. Thank you.
Bye.
Bye.